So welcome everybody to this webinar on the antibiotics guide, which is an open access antibiotic treatment guideline, but really a directed therapy guideline, but I'll talk about it a bit more later. So last year we had a few sessions in various regions, and from every region we have also a local speaker. So we're really proud and happy that to have Natalie Schellack as a speaker. She's the head of the Department of Pharmacology at the University of Pretoria, South Africa, and really involved with infectious diseases, in particularly in stewardship aspects. So we're looking forward to your talk later. But before Natalie will start, we'll give you a bit of background on the International Society of Antimicrobial Chemotherapy and the Alliance on Prudent Use of Antibiotics, and then on the background of the antibiotics guide, and then Hind will talk about the methodology, how we did it, and then Natalie will take the floor. So without further ado, I will start. So welcome everybody to this webinar of the International Society of Antimicrobial Chemotherapy. So this is a society of societies across the globe to really improve the knowledge, but also the use of antimicrobial chemotherapy. And we have really from every country quite some societies being involved across the globe. So we're really proud that we're really a society from various regions, from low to high income settings, and from various backgrounds. So it's really great to see all these societies being more actively involved with all the things that we are doing. So to see how we are working, we have a executive committee, and with the trustees and the executive committee. They also have ex-officio members for various aspects of the society. They also have to have good regional representation. And as you can see, also the trustees and the board of directors is from various parts from across the globe. And then recently, last year in November, we had Sua Kanj to become our president. So she followed up Jeff Coombs from Australia. And she was also part of the development of the antibiotics guide. So she's based at the American University of Beirut. And then the other trustees are myself. I'm actually the president-elect, and really happy to work together with Sua on a frequent basis. And then Anuradha Chaudhary from India, and David Jenkins, who is our treasurer from the UK. So also here, a nice group with various expertise. As a society, we also have a conference every 2 years, the ICC, the International Congress on Antimicrobial Chemotherapy. So last year we had it in Istanbul, Turkey, which was a great success. It was based in Istanbul with great speakers also from across the globe. And in 2 years' time, it will be in around November in the Philippines. So for our activities, so it's not about having a executive committee and a conference. We also like to be active in content, including, for instance, developing a antibiotics guide. So we have various working groups with various subjects, from medicine-resistant Staph aureus to also career, but also to vaccines, but also IPC or urinary tract infection. So if you are interested, feel free to look at those working groups, and feel free, if you're interested to contribute, please contact them or through our secretariat to see how you can be involved. So please also feel welcome to contribute in these working groups. And here is the email address of the secretariat in the right bottom corner. And then besides having the working groups, we have also two journals: the Journal of Antimicrobial Agents, the International Journal of Antimicrobial Agents, the IJAA. And apologies that my slides are jumping by themselves, so I have to sometimes control them a little bit. So Professor Jan Lee from Australia, he's the editor-in-chief of the IJAA. And then the other journal is the Journal of Global Antimicrobial Resistance. Actually, both are Elsevier journals. And then Professor Stefani recently had someone who followed her up as a editor-in-chief, which is Professor Athanasios Tsakris, who started last year to be the editor-in-chief. Then we think, enhancing knowledge across the globe, as we said, because it's part of our mission to enhance the therapy of infectious diseases. We have the ISAC Academy, which is also, you can find the activities of the Academy on our website. So you see various, movies of various webinars that we, for instance, launched, but also e-learning modules some really interesting ones, for instance, on how to interpret, for instance, antibiograms, but also e-learnings on, for instance, fever in returning travelers. But we also like to have people involved by themselves and to do activities that can help them to advance, situation in their setting or to advance a certain career. So for this, we have developed for the last couple of years the ISAC project grants. This is yearly, and also this year we awarded recently 4 projects from Indonesia, but also Australia, but also like Tanzania, and also a group from Switzerland who was collaborating with another low and middle income country. So also here you see, for instance, Africa being involved. So the Mumbili Hospital is involved with this on a IPC project, for example. So also here, a global outreach. So if you see so keep a view out for our social media or for our website when the next deadline is. So and so please see the application details. But generally, the application is quite simple and straightforward. Then the other part of our society is the APUA, which is the Alliance for the Prudent Use of Antibiotics, which was developed in 1989 by Stuart Levy. But since 2019, it's also part of the ISAC and currently being chaired by Pierre Tattevin from France. Also here, we have also a whole governance structure around this, where you see some similar faces from the ISAC committee, as you can imagine, to ensure that where there's a good, overlap, but also here a good global representation. But we do see that, for instance, from the African region, I think some more needs to be done to get more people involved. So if you're interested in APOA, also please reach out to us for this. And then APOA is also active in various aspects of enhancing, for instance, the diagnostics and use of antimicrobials. So we have a newsletter, but also specific webinars and symposia, but also we have position papers, often also published in the journal of the IJAA, the International Journal of Antimicrobial Agents. And recently also we launched the antibiotic cards with some really basic, simple information on commonly used antibiotics. So here a bit more detail. So 16 cards have been developed so far. And interestingly, they're quite often used, so a huge number of downloads. So you can find it on our website, on apua.org or on isac.world. So feel free to look at them and use them. Vietnamese colleagues have also started to translate them, so you can see that people really like to use them and start to get local translations. So membership is free, so please check our newsletters and the website and be involved as you like. So here are also our social media links, so please hook up with us and follow us, and you can also see, for instance, the deadlines for project grants or certain meetings or symposia. So without further ado, it's good to start to discuss the antibiotics guide, because that's what the webinar is really about. So the antibiotics guide team was Suha Kanch and myself, but Hind Kadri, who was a trained ID doctor at the American University of Beirut, so she will talk right after me. But also Neda Kostova and Teske Schoffelen, both based in the Netherlands, have been hugely involved in either the website development or also in the content development. So the why of the antibiotics guide. So what we often found, because we are quite active in many different countries, so we had many signals from low resource settings. There are actually no good up-to-date guidelines, but also particularly also no directed therapy guidelines. And if there are certain guidelines, but often they're commercial guidelines, so you need to pay for them. And currently there's the WHO Aware Handbook, but this is an empiric treatment guideline. And the antibiotic guide is really, okay, you do know the bug, so we do assume there are diagnostics in place, which we think is really important. So you can have directed therapy. So stewardship is also really about being able to have directed therapy. So diagnostics is an important component of the antibiotics guide. Treatment guidelines are really crucial for standard of care, so having good standard of care, but of course it's not a thing in itself. a guideline is a part of an overall sort of good organization of your care, and it's only very effective as the guideline in the context of a functioning health system with well-trained clinicians and laboratory technicians, and the drugs that you need are available, and the diagnostics are available. So you need this supportive environment. So just having the guideline is not sufficient, as you can imagine. And that directed therapy, as I mentioned before, does require diagnostics. So we hope also that this guideline can be an inspiration to go to the board of directors of your institute. We see in guidelines that knowing what the disease is or the resistance profile is crucial for adequate treatment. So only if you know what you're treating, you can be directed, and you can have the right choice of the antibiotic. And in this sense, we can, one, improve the outcome of patients, but also reduce the chance of the development of resistance. So this is the reason why we did it. And for example, with carbapenem resistance, so this is a picture from a paper looking at, okay, what do you do in case of carbapenem-resistant infection or suspected carbapenem-resistant infection, so CRE, that, knowing, for instance, the resistance mechanism, it does matter. So carbapenem resistance is not in itself one thing. You need to know exactly the mechanism because it matters, because the choice of your antibiotic matters. So, so that is quite crucial to know what you are treating. So in conclusion, so the website is launched last year during the World Antibiotic Awareness Week. It's freely available currently in English. It's open access. Feel free to use it. We are now looking at the option of having various translations. So we're exploring the Serbian language at the moment. It's really a living guideline. So recently we added the gastroenteritis chapter to it. Please, if you see mistakes or, nothing is perfect. So we also adjust as needed. But we need to make also certain choices. So sometimes you see some choices where you think, okay, maybe we do it differently. This is always possible, but, you can't, please everybody. But Hind will explain a bit more how we did it. And the nice thing is that we have really 22,000 views, for instance, in December. So really see that the site is being used quite well. And of course, we hope after this antibiotics guide webinar in the African region, you think is useful and hopefully also an inspiration. So Hind, without further ado, I will stop sharing and give the floor to you.
Thank you, Dr. Heiman, for introducing me. Thank you for your guidance and leadership with Dr. Kanj as well on this project. And I want to thank Neda and Teski, my colleagues, for their amazing teamwork and collaboration. So today I'll be presenting about the ABX guide to tell you what is in it and what is not. I'll give you a briefing about how we developed the ABX guide through several steps, and then how it turned out in the end through the web-based platform, and how to use it, and also a future look on our plans for this project. And the QR code is available, and as well as the link below on the slide. So this is just a summary slide of the steps I will be talking about in the coming slides. I'll quickly review it. It's just a start. When we wanted to start for the ABX guide, we wanted a background of information from the clinicians. So we underwent a stakeholder survey to understand what is important to them and what is their scope of interest. After that, we had several headlines plotted, and we drafted them. We drafted some ideas, and we had the guideline screening for each headline. We did a literature review and compiled evidence in order to tailor it to fit into resource-constrained settings. Now, the most important step was the validation phase, where we had an internal review by our project team members, Dr. Heiman and Dr. Kanj. And after that, we had it peer-reviewed by 2 to 3 independent experts from ISAC or APUA, based on the, or according to the topic, or according to the headline we chose. And then we had a final review by consensus. We had a final draft that was implemented into the web-based platform, and then promoted by a series of webinars that were global and continental. So starting out with the stakeholder survey, as you can see, it started in January. We conducted it in January 2022. So it's been about 2 years when we're working on this project. We had around 194 experts, and more than half were from low to middle income countries. We asked them what are the important infections for them that they suggest to include in the guide. And basically, most of them had reported bloodstream infections, respiratory infections, but other infections were also given, other ideas were given in different proportions. And then for each headline or for each infection, we asked them, what is important information you want us to include? And basically, because it is a pathogen-directed guideline, most of them answered, or the majority answered, common pathogens with preferred therapy as a primary regimen and an alternative regimen. And we also based that based on susceptibilities. We provided information on the duration of treatment, allergies, or what to do in cases of allergies and toxicities and other considerations. We did also ask them how they wanted us to display the information, and most of them reported that they wanted to be in a web-based platform. So after we had several headlines or several topics, or we could say syndromes, that we chose, for each syndrome, we did a literature review of about 5 guidelines for each chapter, mainly from the American guidelines, European guidelines, the African guidelines. And for some guidelines, or for some chapters that had scarce evidence, we depended on case series, case reports, or expert opinion. So we compiled all of that evidence, all of that data, and we tailored it to resource-constrained settings. Which means we chose the antibiotics or the regimens based on the availability, on the cost, on the dosage, the mode of administration, of course, if we were targeting inpatient or outpatient hospital settings, and also the duration of therapy did affect the cost, so we were taking that into consideration to make it as minimal as possible. This was similar for the alternative regimens that we provided. And all of our antibiotics were in accordance with the WHO Access Aware classification, where we actually the Aware classification, where we intended to encourage clinicians to use the access group of antibiotics. Okay, this is just a scheme to show you how we thought when we developed the guide. So, for example, for a certain syndrome, we had a detected pathogen because this is pathogen-directed. And this pathogen was either susceptible or not susceptible to a certain antibiotic. And based on that, we had a primary regimen and an alternative regimen. And for each antibiotic, we would think, is this locally available in these countries? Is it suitable in for this infection? Should we provide it initially in the oral form or in the IV form? How severe is the infection? And then we also decided on the duration and the alternative regimen similarly. And we provided a comment section on for other issues, such as immunocompromised patients, patients with comorbidities, patients with severe illnesses who need to be hospitalized, or laboratory markers that should be monitored with the antibiotics in the comment section. Okay, coming to the validation process. So in order to use this antibiotics guide in a comfortable way, we had to validate it internally and externally. So basically, we started with an internal validation by our team members, by Professor Heiman and Professor Kanj initially, and other experts from the team. We did several back and forth emails, several meetings, several commentaries on the documents itself, and we adjusted accordingly several times to reach a final initial draft. And then after that, we had it peer-reviewed or externally reviewed by independent experts, and sometimes depending on the syndrome, we would send it to different independent experts from ISAC or APOA for further review and further comments and further adjustments or expert opinion until we reached a final consensus on these guidelines. And after that, we uploaded it into a web-based platform and promoted it through the series of webinars we are doing. So if you open the link on the ABX side, you would see it's divided based on organ system, so it is easy to use. This is probably the initial page you would see when you open the link. And if you press, for example, on respiratory infections, you would go into community-acquired or hospital-acquired and choose. You choose the syndrome, and then you choose the pathogen, you choose the susceptibility, and then you'll get the primary regimen. If you do press on nafcillin, for example, here, you will get the dose duration and the administration, the mode of administration. You'll get more than one alternative regimen. In case penicillin allergic patient or a non-penicillin allergic patient, you'll also get some comments on the antibiotic itself or something you need to monitor while using this regimen. So as you can see, it is easily accessed and user-friendly. It's online, it's free, it's optimized for resource-limited settings, and it's complementary with the colors with the WHO Aware book. So this is my last slide on our future plan for the ABX guide. Basically, you know that with the global changes in climate and the political changes and the wars, there are new syndromes and emerging pathogens coming up. We also have new antibiotics in the pipelines. So we are intending to do an annual review for these for the ABX guide, and also transform it into mobile access for easier access, and translate it into multiple languages, as Dr. Heiman said. But we're also trying to, or want to study its applicability and effectiveness in the hands of clinicians. We might do surveys, get some feedbacks, and do some adjustments on that. And also we want to study its effectiveness globally in accordance with the Global Action Plan on combating AMR and encouraging antimicrobial stewardship efforts. And with that, I'll end my presentation, and thank you so much, Doctor.
Yes, thank you so much, Heiman, and colleagues of the International Society of Antimicrobial Chemotherapy, for allowing me to talk today about something that holds close to my heart. That is the issue of making a case for patient safety and antimicrobial stewardship. And it almost augments and highlights the role of having proper guidelines like the ones that you've set up. So I'm going to talk about an overview of patient safety, some strategies to combat AMR, which includes guidelines, of course, and then what future opportunities do we have for AMR? Maybe just to go back one slide, you will all recognize our lady there that was told to wait, one of the Greek mythical features, and she couldn't wait, Pandora, and of course she opened the box, and she unleashed havoc, but at the end of the box, she still had hope. So with patient safety and using patient safety in antimicrobial stewardship, it provides us just maybe to think again about how do we use antibiotics, when should we use antibiotics, if we want to keep our patients safe. So normally I like asking this question, but we don't have a live audience, but I still want to share with you today that which is the most dangerous if you were to look at this. You know, you see someone there rock climbing, someone bunch jumping, and then a whole group of people working on one patient. And when we administer antibiotics, it's almost like this group of people that are working on one patient administering antibiotics, which can be very super dangerous, of course. Is it more dangerous than rock climbing or jumping off a cliff? Let's see. So antibiotics in its own, if you think about patient safety, and we'll get to the answer just now, you can see that there are many ways in which one can actually acquire antibiotic drug reactions. So sometimes we think, oh, we're just going to give an antibiotic just because we think. We call it this almost like this blanket approach, or sometimes we drink it as a sedative, as a clinician, so that we can sleep. But if you think of your body almost as a city, you know, the good times, your drugs are on target. So if you look at antibiotics that come in almost like city cleaners, they are there and they are meant to clean up all of the bad bacteria, the criminals. But unfortunately, as you can see here, as part of the ADR mechanisms, unfortunately, they also clean up some of the good guys, our natural microbiome. And then that disrupts almost like the city's whole normal good traffic flow. And we get off-target, that's what we call off-target antibiotic drug reactions. And there's three main ways. It's either direct damage, that you can see on this slide. So off-target, there's direct damage. It's tiny factories, so antibiotics can block the factory doors, like what you will see here with cubalin and megalin. Or it can completely mess up the assembly line, like you see here off target. That's ER stress. Or it can just activate the body's own self-destructive mechanism and cause apoptosis. In the case of aminoglycosides, it can cause kidney damage. We can develop C. diff, fluoroquinolone-associated urticaria, penicillin angioedema, and abacavir hypersensitivity. And then the immunological one is, unfortunately, your immune system is like the trained police force. It remembers the criminal. So within antibiotic safety, and if I had to ask you again, so how hazardous is healthcare and antibiotic use? You can see even directed and undirected adverse drug reactions. There's always a risk of untoward adverse events if we don't use antibiotics properly. So it seems counterintuitive that the healthcare industry is the most unsafe, but it is. In the healthcare system, it's because we've got lots of people working on the same patient, and adverse events then happen. Someone forgets to ask, what is a patient? Is the patient allergic to anything? A patient has got a massive a side effect or an adverse reaction. And that can even lead to a high incidence, like you can see here with Stevens-Johnson syndrome or emergency visit. So we can't always assume that just using antibiotics is safe. And that is where the importance of even having guidelines makes it, we cannot stress that point enough. So where I am based in sub-Saharan Africa, you may have seen this study published and on slides many times, but it is estimated that deaths associated with bacterial AMR in 2019 is 4.95 million. That is a lot. And attributable to a bacterial AMR is 1.27. So, but where we are in sub-Saharan Africa, it means that translates for respiratory deaths. That's about 27.3 people will die for every 100,000 people. So lower respiratory tract infections for us with the 6 leading pathogens, Escherichia coli, Staph aureus, Klebsiella, Strep pneumonia, Acinetobacter, and Pseudomonas aeruginosa makes targeted antibiotic therapy super, super important. So, of course, we have to think about Soteria. Soteria, all of these are, of course, very powerful women. And she was the goddess that personified spirit of safety and the deliverance and the preservation from harm in Greek mythology. So this concept even comes from, a longer time than we were on the planet. So if we think about the ethics in patient safety, so are we ethically responsible to consistently provide good patient care? And how does that tie into having patient guidelines and having a community of people that work together, like the community where we are currently at, the International Chemotherapy Community? So, of course, there's always an ethical basis of safety. We have an ethical imperative, a legislative obligation. The aim of healthcare is to keep patients safe. But antibiotics, due to its nature, has a risk of keeping people unsafe. So we have to really think about it 2 or 3 times. In South Africa, we have a national antimicrobial stewardship framework where we have shared responsibility and where our foundation is education, and looking at communication and public awareness, surveillance and stewardship and IPC, and all of that feeds into governance. Because we have to think about, when we look at antibiotics, we think about utilitarianism. So utilitarianism in its ethics is a consequentialist theory that says the morality is based on the outcome of the intervention. So if we use antibiotics according to a guideline and we follow the steps and we follow evidence-based practice, then that keeps us on a moral course. But if we don't, and we only look at the moment, in other words, we only think about that moment and getting the patient out of our office, then of course we can create damage and harm to our patient. So COVID-19 has underscored benevolence and utilitarianism, where it was disproportionately shared, the vaccines and antimicrobials. But now antimicrobials and vaccines belongs to everybody, and there should be justice. Egalitarianism, sufficientarianism, and prioritarianism. So it tells us that we have to look at this resource to have it to the best of the community, to improve the situation for the worst of the society. And I really believe with having guidelines and following guidelines and evidence-based practice, it gets us there. So now I've mentioned many of these, but it's always balancing excess and access. You know, what is our ability to access antibiotics, but not in excess. Personal versus shared interest. So if I don't take my antihypertensive today correctly, I'm the one that suffers. But if I misuse antibiotics, the whole community suffers. And healthcare providers need to come on board, because clinicians must prioritize patient safety by judiciously prescribing antimicrobials. In other words, you know, some of the other countries have been really good at saying, no, you know, it can only be prescribed at a certain level. But unfortunately, in other areas of the world, there's still antibiotics that can be bought over the counter, even IV antibiotics. And we know that resistance is only a plane ride away. But if we think about this, and we think these antibiotics that are so readily available can not only worsen resistance, but can cause major damage to patients. And then we have immediate versus chronic threat. So doctors would often respond to the immediate threat of a palliative patient, but not considering the chronic threat with that untoward use of antibiotics for the future. So traditional patient safety is the concept where we think about now Prometheus and the Minotaur and Medusa and Narcissus is we have to cure sometimes, to relieve often, maybe just symptoms. But we have to educate patients unceasingly to tell them, you now have a viral infection. So these are going to take away your symptoms and to comfort them as well. But oftentimes in antibiotics, only in the very worst instances will be the place to cure. Just to tell you, in South Africa, we've had major cost implications, medical negligence claims in 2022. The South African state paid out a total of 9.7 billion rands in medical malpractice. And in Gauteng, where it's the province where I am in, 228 million for medical negligence. So the payouts ranged from 7 to almost 18 million. And many of these are ADR reactions where patients were asked, are you allergic to penicillin? They said yes, and the patient was given a cephalosporin. So I've already asked you, but can antibiotic use really be a risk for patient safety? So on the right-hand side there, you will see the black swan. So the black swan is almost, it symbolizes an unexpected event. When they found the black swan, I think it was in Tasmania, they didn't expect to find even swans, and now they found this black swan. So just like any other medication, there may be risks that we did not anticipate. So for example, in 1937, when they discovered antibiotics, they knew that there is this risk that there's going to be resistance, but how promiscuous these antibiotics are, for example, Escherichia coli 131, so promiscuous, even more than a high school student. So in South Africa, our CRE rates are sitting at about 20 to 25%. We have to use the last resort antibiotics. So 1 in every 5 inpatients are treated with antibiotics is being harmed. And in the study on your left, you can see there's even some countries like Australia that is now measuring the risk of using antibiotics as medication safety parameters and looking at the number of incidents that has occurred due to the unnecessary use of antibiotics. So there's the patient safety and then the patient efficacy challenges. So within antimicrobial stewardship, you can see that patient safety is sitting right in the corner there. It says we have to optimize the clinical outcome, minimize unintended consequences, and then improve the patient's safety and reduce healthcare costs. So me talking about safety is nothing new. It's just refocusing on how can we ensure patient safety. So this was also a paper that was published in 2023, and it was done after COVID, where it highlighted all of the aspects and the care management and the places that we missed, the shortages and staffing, and all of the patient harm that was accelerated by COVID. And you can see one of the areas that was highlighted by COVID-19 as a catalyst for accelerating global action on patient safety was antimicrobial resistance. There was inappropriate and excessive use of antibiotics. You can forget the use of macrolides massively. I mean, for anti-inflammatory, the use of ivermectin, I don't even want to go there. Increase in transmission of resistance, pathogens, and healthcare safety. So following that, in 2019, or even preceding that, the World Health Assembly was convened in May 2019, and there was a global watershed moment for patient safety, where they have a charter. And this global patient safety action plan is 2021 to 2030. And what's interesting in this charter is antimicrobial stewardship, and what antimicrobial stewardship and all of the champions are doing towards keeping patients safe and preventing antimicrobial resistance. So I was lucky enough to join this in Montreux in Switzerland. And from South Africa, one of the commitments that we've made is that we have to start really looking at how we implement our framework and our guidelines, and how are we going to follow, because if you have a guideline, what follows onto a guideline is surveillance. Because the surveillance will not only include antimicrobial use, but the untoward effects of antibiotic use and how we are keeping our patients safe. Signed by everyone, civil societies, the government. This was now a long time ago, the framework. And patient safety is incorporated in our national core standard. So you can see we've got 7 subdomains that looks at our national core standards. And in the subdomain of 2 is patient rights. And interestingly enough, you can see patient safety, clinical governance and care, infection prevention and control, which is the orphan child of antimicrobial stewardship. That's super important. So we really want with safety is to have quality nursing, clinical care, ethical practice, reduce unintended harm in healthcare users or patients by preventing or managing problems, including healthcare-associated infections, and to support any affected patients or staff. So how are we doing in South Africa in terms of monitoring and surveillance? We still have a patient survey patient form, so it's difficult to have a point prevalence survey to even monitor any of the guidelines that we've implemented. That has changed now more recently. We developed a web-based application to test in some of these hospitals that were never really meant for Wi-Fi. So it had to be a web-based application. And we tested it and it was easy to use. And the people, the data collectors said instead of performing a point prevalence survey over 30 minutes, they were now able to do it within 7 minutes to see appropriate use of antibiotics and even just a point prevalence use of antibiotics. So then we rolled it out over 18 countries. This was published in 2023. And you can see, surprisingly, where we thought it would still be the beta-lactams is a class. According to our guidelines, it's correct in terms of where it is prescribed, access and aware and resistance. Places where it is prescribed is correct, and according to the guidelines, it is correct. But what we didn't expect was fluconazole to be used so often. So that, of course, gave us an insight into another major challenge that we have in South Africa is prophylaxis with HIV-positive patients. So we've also rolled out this app throughout other African countries to try and make sure, are we using antibiotics according to access, watch, preserve, in the ICUs, medical wards, according to the guidelines that's available. But talking about guidelines, we have to also ask, are we there? Are we able to implement? So this was a study published in 2022, where Deidre Engler and colleagues looked at, well, we've got all of these guidelines. Let's go and speak to the people on the ground, the people that are working in the facilities. Can they implement it? Many of these nursing staff said, well, they know about the guidelines, but sometimes if the guideline says you can only prescribe this after you've done a blood culture or a smear culture or a sputum, they don't have access to the diagnostic aspect of stewardship. So they know what to prescribe, but they cannot justify the prescription. So that is something that we also have to look at. So just in closing, and maybe just to say Athena's wisdom, and AMR, Athena, of course, a female again, she was the Olympian goddess of wisdom and good counsel, and of war and the defense of towns. She was known for her heroic endeavor. Some great examples of other countries that has really used antimicrobial stewardship as a focus for patient safety. So instead of having fear-mongering, just changing the narrative to say, we are not going to give you these broad-spectrum antibiotics because it can just completely eradicate your microbiome, and you have something else. So they just use the link of a reduction in Clostridium difficile as almost as a marker of how their patient safety is, how they are looking at patient safety. And even if we ask people in the schools, the students, etc., these are some studies where we asked fourth-year students across South Africa, what do they know about antimicrobial stewardship? What do they know about patient safety and resistance? There still isn't consistency in what we teach our undergrads. We asked our veterinarian students as well, what are their perceptions around stewardship and safety. They have a completely different angle in terms of they also have guidelines, but the cattle is very expensive, and in South Africa it's also seen as almost as a cultural figure. So you would do anything to keep it alive. So metaphylaxis and within the One Health and guidelines deserves a lot of attention still in our country. And here one of our medical students just wrote a paper that was published last year, where he said he never realized that antimicrobial resistance is such a challenge and is going to cause such a major threat for patient safety, because it's always just a class that is taught at the end of lunch or Friday afternoon, so everyone's falling asleep. So of course, this is where many of my colleagues are in terms of having patient safety. So there's a guideline, and within this guideline, drug-drug combinations, you have to look at the patient characteristics as well, where you are now evaluating the microbe, the host, and then you have an individualized prescription. And with that individualized prescription, you can actually prescribe a script to the patient and reduce harm and optimize efficacy. But we are still a while away from this. Okay, so ABX guide as a solution for AMR in patient safety. In closing, Chair, I hope I haven't gone a long time over my time, but if you look at it, what's nice about it is it's an open access platform with practical applications, and it's something that we can integrate into our daily practices. There's African healthcare contexts, resource optimization, decision support tools, resource conscious implementation. So I think many of these and this ABX guide solution can go a long way in tackling many of the problems. The other challenges in terms of monitoring this is something that we will still have to give thought to. Improved dosing in South Africa with PKPD is almost like a high-hanging fruit, but currently we are also busy participating with other groups around the world to see the beta-lactams and how it's being prescribed according to the guide in very septic patients. If the same holds true and if the dosages are correct according to our South African populations and other populations around the world. But even, this is a paper published last year, even just looking at access. So in South Africa, for example, only 21 and most of the clinicians didn't have access to assays, and 26% of sub-Saharan Africa only to vancomycin and aminoglycosides. So if we include some of that in our guidelines in certain settings, it may be challenging to implement. We still have to rely very, very heavily, and I think everyone does, on vaccines as part of a strategy. So, you know, life expectancy vaccines, a lifelong, providing lifelong vaccination as an option. Because vaccines, clean water, and antibiotics have changed the life expectancy in the 1950s, I would say more or less from 80 up until 100 years old. And if we can use the two together, of course, that would be the first choice. So the role of bacterial vaccines in the fight of resistance in terms of patient safety is a major, major win. But the column on the right, where we don't have vaccines, Acinetobacter, Helicobacter, Pseudomonas, Staph aureus, Enterococcus, and Enterobacter, are one of the organisms that we face, as a big burden for us in sub-Saharan Africa. And vaccines is important because it preserves the microbiome, so thus keeping the patient safe. And it could also affect resistant infections, with some existing empirical evidence that vaccination has considerable direct and indirect impacts on resistance. So just in concluding is that everybody on this call and on this webinar and in this international society knows that antimicrobial resistance is a leading cause of death globally, and the highest burden is in low-resource settings. But if we include patient safety and evidence-based guidelines in a way that is palatable to everyone, in other words, education needs to go into the equation, as well as ethically disseminating the information and making the concept of stewardship more palatable, there could be great strides made for us. And just to say as a joke, so this is the Watchdog Group promotes strategy to end medical errors. You'll be happy to know we have new procedures that will prevent Mrs. Brown. And then Mrs. Brown says, my name is Mrs. Smith. So thank you very much for this opportunity to join this society. It's very exciting for me. I'm very thankful to be with you today. And if you need to contact me, this is my contact details. I'm available at the University of Pretoria, and that is my email address. Thank you so much.
So just to introduce myself, I am the board chair of the APUA, the Alliance for the Prudent Use of Antimicrobials, and I work in a hospital university in Western France in the infectious disease unit and the intensive care unit. So my talk today will try to advocate to keep some kind of pathogen-directed antibacterial treatment, which we don't do very often, but that is really important. Then we keep this kind of prescription of antibiotics. So these are my disclosures for the last 5 years, mostly working in as a scientific committee for the development of new antibiotics that we desperately need. So a few slides have been already presented on what is APUA. This is the picture of Stuart Levy, who was the founder of APUA. It's an old society because it was founded in 1981, but he was really a pioneer in many aspects. And he was, for example, the first to talk about the One Health problem, the fact that if we use too much antibiotics in the animal industry, we will have the problem to get the resistance coming from the use of antibiotics in the food we eat. A few years ago, we merged the Alliance for the Prudent Use of Antimicrobials with the International Society of Antimicrobial Chemotherapy, especially the group at ISAC that was working on antimicrobial stewardship, to try to join forces. And because we had the same kind of objectives and mission, which is to strengthen the fight against infectious disease. And to do that, we have to ensure that the patients who are in need of antibiotic treatment will have indeed access to effective treatment. And for this, we need to promote the appropriate use of antibiotics so that we decrease the risk of antimicrobial resistance. And Heiman showed you the kind of activities we have. So, for example, we are sometimes invited to talk about the importance of appropriate use of antibiotics, such as in this global ministerial summit last year that was focused on patient safety. How can we make sure that our patient will not acquire multi-drug resistance and will have access to the antibiotics when they need it? We have these newsletters that were presented already, and they are available on the website. You can just look at the APUA website, and there are newsletters, 3 to 4 every year, probably on topics that you would find interesting. There are webinars either in collaboration with other society or even organized by ourselves as APUA. We publish the antibiotic cards. So this is an example of the kind of cards that were prepared. It's the aim is to provide to everyone who want to use it in the world a one-page summary of what you need to know about each antibiotic when you prescribe it. And we have some first set was in English, but some of them are becoming to be developed in other languages, such as Vietnamese recently. And we have position paper. I will come to back a little bit later. And we were also partners to this very exciting and very important project of the pathogen-directed treatment guidelines. So what do we think? It's very important that we have guidelines that are based on the identification of pathogen. If you just think about the way we use antibiotics currently in 2024, you may say that probably everywhere in the world, more than 90% of all the antibiotics are prescribed as empirical treatment. And probably this is also true, and this is maybe even more sobering, is that more than 90% of these antibiotics that we prescribe empirically worldwide are not adapted subsequently, either because the results of the microbiological testing are not available to better prescribe antibiotics after the empirical treatment was started, or sometimes it could be scaled down, but it's not because there is no physician to look at the results or the results come too late. So it's really the truth, and it's probably true everywhere in the world, even in high-income countries such as the Europe of North America, that a very large proportion of the antibiotics that we use in 2024, we just do it not really blindly, but empirical treatment with no documentation of what was the bacteria that were responsible for the disease that we are trying to treat. And how come that it's so low, the proportion of antibiotic prescription that is based on reliable microbiological documentation? So there are probably two major reasons. One is that the current organization of care is that we just see patient once and we have to decide very fast what kind of treatment we give, and we may well not see again the patient whether or not he's improving because he was just outpatient or because he will be managed by other people if he remained in the inpatient hospital. And the second reason why we don't have so much antibiotic prescription that are based on reliable microbiological testing is that the current microbiological test, most of these tests have a turnaround time that do not allow common use of targeted antimicrobial therapy. So that's probably the reason why, and I might talk to you a little bit about that. The WHO, when they had to publish and prepare their antibiotic book, they mostly focused on empirical treatment. And so, for example, from this AWARE book, antibiotic book, which is a very important book, if you see, for example, community-acquired pneumonia, it is well written in the guidelines, and it's the same for many, many other infections, that the laboratory tests are usually not needed, so that patient not only will be treated empirically, but will remain with empirical treatment until the end of the treatment. And why is it not good that we always, or most often use empirical treatment for infections that we treat. So if you think about what we do when we do empirical treatment, we cover the main pathogens that are possibly involved and are responsible for the disease that we are trying to treat. And on the other hand, when you could do targeted treatment, not only you will use narrow spectrum because you will just target the bacteria that is responsible for the infectious disease, but you will also have the opportunity to select the optimal drug. And I will come a little bit to that later, but a good example was given just previously about how you should treat Staphylococcus aureus, methicillin-susceptible Staphylococcus aureus pneumonia, for example. And you will see that not only narrow spectrum is better in terms of ecology for not promoting antimicrobial resistance, but it may also be better in terms of efficacy for bacteria such as Staphylococcus aureus. However, we cannot, in many situations, wait for the results of the microbiological testing, and it's true for pneumonia and it's true for many other diseases. So we have to acknowledge that empirical treatment is the only reasonable option in many situations. However, the optimal selection of empirical treatment requires that we are aware of what is the epidemiology for the main infections that we see in our practices, in our sites, and probably the kind of infectious disease they see, for example, in the Netherlands is very different in terms of susceptibility to antimicrobials than what you may see if you work in India, in Brazil, or in Africa. So it's very important that we have at least a proportion of our infection for which we have the microbiological documentation so that we can adjust to our local epidemiology. If you look at the way we prescribe antibiotics, and I borrowed this slide from Alex van Velkom that he presented at the ECMID in 2019. So from the left to the right, you will see how we used to prescribe antibiotics. And I was mostly talking about empirical treatment because it's what we do most of the time. And when we prescribe empirical treatment, most of the time, it's because we have some data, including antimicrobial susceptibility testing on the kind of bacteria that can give, for example, pneumonia, otitis, urinary tract infections, or things like that. What we would like to do more, and what is focused, what is the target of the guidelines that we are talking about today, is to try to prescribe antibiotics with some clues about what we are trying to treat. And it may be either rapid tests that are not very commonly used and that not as accurate as what you have with microbiology results, or the full microbiology results. But as you see on this scale, the full microbiology results will take more time. But rapid tests could be, for example, if you have pharyngitis and you think it could be due to Streptococcus A, you have some rapid tests that can tell you directly that is Streptococcus A, and then you can use the guidelines that was just presented to use the best drug that you can give to your patient for a Streptococcus A pharyngitis. And it can be the same, but on the way to not prescribe antibiotics for the rapid test for respiratory virus infections such as COVID-19 or influenza, or more recently the RSV. And later on, if you are working in a rich environment that you can have more access to other tools such as therapeutic drug monitoring, MICs, or even biomarkers, it will help you to adjust your antibacterial treatment throughout the process. Going back to the fact that targeted antibacterial treatment is better when it's possible than empirical treatment, I have just one example that I think is very interesting to think about. It's the topic of methicillin-sensitive or susceptible Staphylococcus aureus bacteremia. We all know that for this disease, most of the beta-lactam agents will be active, at least in vitro, and it's what you will see on the drug susceptibility testing from the lab that will provide you with the results of drug susceptibility testing for methicillin-susceptible Staphylococcus aureus. However, there has been this very interesting study published by the colleagues from Israel a few years ago, Michael Paul and colleagues, where they look at 541 patients who had Staph aureus bloodstream infection, methicillin susceptible, and they performed a multivariable analysis of the risk factors to die when you have methicillin susceptible Staph aureus bacteremia. And what they found is that if you did not receive anti-staphylococcal penicillin such as oxacillin or cloxacillin, or the first generation cephalosporin cefazolin that is probably at least as effective as anti-staphylococcal penicillin, you have between 2 to 3 times higher risk of dying. And it's not because these drugs are not active in vitro. They were active in vitro, and that's what was given in the drug susceptibility testing result for these patients. So, for example, ceftriaxone, cefotaxime, they are not inactive drugs for methicillin-susceptible Staphylococcus aureus. But the truth is that if you use anti-staphylococcal penicillin, you will be more effective. And it's not only this study that found this, but a few years later, the same kind of study, just observational multicentric study that was performed in France by Vincent Lemoine and colleagues. They analyzed more than 2,000 patients with Staph aureus bloodstream infections. And what they found is that if your first-line antibiotic regimen did not include anti-staphylococcal penicillin or vancomycin when it was methicillin resistant, you are more likely to die. And it was, again, significant in multivariable analysis. So what do we need to prescribe antibiotics the best way that we can? It has been already presented, so that I can go a little bit fast on that, but you need to have a good policy regarding the diagnostic tools that you have to better prescribe antibiotics for your patient with infectious disease. And this is one of the position paper that was published in collaboration with the ISAC and the APUA last year in the International Journal of Antimicrobial Agents by Johnny Zakur and colleagues. And they advocated for the very important role of good diagnostic tools for good antimicrobial stewardship in the fight against antimicrobial resistance. And as you see on this table, the general consideration would be, for example, very obvious, such as sampling prior to start antimicrobials, doing quality sampling by well-trained professionals that may include the nurses or the doctors or other healthcare workers, could be transported fast to the lab and should be analyzed fast within the lab. For urine cultures, you know that it has to be sampled properly and sent to the lab very fast, within 2 or 4 hours at most. Blood cultures, the importance is to have the good volume, the good blood volume, otherwise it will be much less sensitive than it should be. And for respiratory cultures, not going into the details, but you know that there are many instances of respiratory samples you send to your lab will not be of any value because it's not the good sample, so it was not sent at the right time, or it was just sent after starting antibiotics, for examples. And taken from the same paper by Johnny Zakur et al. That I really encourage you to look at because it's available open access, and it really provide a good review of what you need in terms of diagnostic stewardship to have a good antimicrobial stewardship policy. But again, it's really very obvious for many of us that you need to focus on good diagnostic tests for infection if you want to be a good prescriber of antibiotics. And it does not mean that you should always wait for the results of this diagnostic test to prescribe antibiotics, but whenever you prescribe antibiotics, it has to be fed by at least some part of a diagnostic test so that you are sure that your empirical treatment will be as good as it can be. So in conclusion, empirical antibacterial treatment will probably remain the rule for most antibiotic prescription and for long, because there are many situations where you need to prescribe antibiotics when you see the patient. You cannot wait 2 or 3 days to have the identification of the bacteria, and even less the drug susceptibility testing. So we are not telling that empirical antibacterial treatment is not good. We do that. It's the main way to prescribe antibiotics in 2024, and it will probably remain that for long, and it's even true in high-income countries. However, we have to keep an eye on the possibility to have pathogen-directed treatment, which ideally should be done whenever possible for every patient. But if you're working in low and middle income countries, and for example, your patient cannot afford, or your laboratory cannot afford doing bacteria identification and drug susceptibility testing for all patients, at least try to organize the things so that you have a proportion of your patients for whom you would have a good information of what are the pathogens and what are the drug susceptibility testing. And this is important steps requires that we advocate for diagnostic stewardship worldwide, and it's probably one of the area where we really have a lot to do within the next year to make sure that in every country of the world, they will have at least some diagnostic facilities that will help to monitor the kind of bacteria and their susceptibility to the antibiotics, so that the empirical treatment will be good. We need to perform regular studies to monitor local epidemiology for common infection, and it has to be repeated over time because, as you know, antimicrobial resistance may change the way it is. We have to work more on the development of rapid diagnostic tests, and we have to spend more time for prescribers, but even patients' education, so that they don't use the antibiotics that were left over in their pharmacy for the next time they got an infection. It's always better to go and see a prescriber that will help you to choose the best antibiotics we need. And I will just finish by acknowledging all the people that are working with us at the APUA board, including Heiman, that you well know, but many other people from the rest of the world. And we are all trying to work in this direction of providing the best antibacterial treatment we can for every situation. And my last slide will be that one. You are all welcome to join APUA, to join your forces to our forces. You have here the website. And as was said earlier by Heiman, it's at no cost, and you can just join us to participate to some of our activities. And you see here the world map of members from APUA that was from last month. So I think it's not very different. And you see there are still many countries where we don't have APUA individual members to join. I want to thank you for your attention.
Well, okay, we'll speak during the next 15 minutes maximum about our results of the point prevalence survey in Latin America countries. If you have rational prescribing, just a summary of this. Well, this story began many years ago, before the pandemic. In 2019, Pan American Health Organization started a program for implementing and strengthening antimicrobial stewardship programs in Latin America. Remember that you have the translating to the subtitles available on the screen, just in case for my bad English. Included always joining the Ministry of Health of different countries. There were official programs, different interventions. One is the distant learning course that's not here, of PROA stewardship programs, and then holding monthly meetings with hospital teams for training on different components of in progressive form of antimicrobial stewardship programs. Many of the colleagues that are here from the different countries that I will name them were included in these programs, plus a voluntary implementation of a point prevalence survey of antibiotic use in hospitals. It was voluntary. Another thing that was voluntary but was more insisted from the ministry and for the PAHO team to be done were the baseline self-assessments of these programs. That was the modification of our WHO baseline assessment, that is a checklist. And then all the hospitals, the facilities from this program, from the different 5 countries, that adhered not only to the monthly general meetings, but also to the voluntary implementation of the PPS and the checklist production, the checklist completion, were having with the coordinator team an individualized meeting, were gathering up authorities, stewardship team, the nurses in infection control, etc. Then we were there giving feedback of the results of both integrated feedback of the PPS as well as the checklist. So we think that this was very useful for every voluntary hospital that adhered to the program to have the recommendations. From 2018 and before the pandemic, the whole program implemented was in Peru, Salvador, Paraguay, Cuba, and Mexico. And then post-pandemic, or at the end of the pandemic, in the year 22 and 23, in Chile, Peru, Colombia, Mexico, Argentina, and Panama. Argentina didn't participate to the PPS because Argentina has already a PPS included in the VIDA program from the Ministry of Health. So the other 4 or 5 countries, 4 countries and 1 hospital from Panama, conducted the second cohort of the PPS. This is an adaptation of the WHO PPS. And one of the advantages is that of these studies, unlike other PPS, our group, the PAHO coordinator, that's Paola Lichtenberger from USA, Jose Pablo Diaz from Costa Rica, Jose Luis Bustos from Colombia, living in Guatemala, and myself, monitor every day the daily upload of REDCap every day on daily basis, and discuss with hospital coordinators the criteria for adherence to GPS. So all that we will see as compliance with clinical practice guidelines are the better approach to the reality, because it's was not only a self-assessment of the rationality of the antibiotics prescribed, but also a discussion with the expert group. So briefly, the results. This is the first publication, the first cohort, performed in some countries, and is already published in the ISAC in 2022. In this first study, there were these countries, Cuba, Mexico, Salvador, Peru, and Paraguay, a total of 33 hospitals included with more than 5,000 participants. And the second one that it's under, we are drafting, revising the always think that's the very final version of the draft, but we are very advanced. So we think that the next month it will be submitted to a journal to be published. The second cohort that was more than double in patients and more than double in hospitals. Peru, Mexico, Chile, Colombia, only one from Panama, pediatric one as a pilot one. So we'll show the most important comparing results, variables. So we already said that 33 hospitals in first cohort versus 67, more than 5,000 in first and more than 11,000 in the second one. The prevalence here are some green or red flags. Regrettably, we'll see more red flags or numbers than green ones. The prevalence was, it's usually about half of patients that are admitted that day in the hospital, that's excluding emergency wards and chronic care or daily patients under dialysis or therapy, chemotherapy, etc. for oncologic malignancies. But the other ones, half of the patients were under antibiotic treatment, that they sort of survived. A little bit, not just a little bit, 6% less. We are not establishing statistical results here. In the second cohort, with a prevalence a little bit under half of patients. The results in antibiotic were directed for treatment in 74 and 76%, so nearly identical. Something similar for prophylaxis, both surgical, 11 and 14, as well as medical prophylaxis. Unknown, 6% and 3%. In the second cohort, we did our best to avoid unknown results. Diagnoses are very similar, as all PPS in the world are similar. 1/4 of antibiotics were directed in terms of treatment, not prophylaxis. We're targeting pneumonias, followed by non-surgical skin and soft tissue infections, abdominal infection, infections of the urinary tract, clinical sepsis without bacteremia, so clinical sepsis, and surgical site infections. You see that they are very similar, probably, as you are the same pathologies you are seeing in your daily practice. Regarding main antibiotic use, we have a huge use of third generation cephalosporins, mainly ceftriaxone, terrible use of ceftriaxone. We'll show it later in the conclusions. That was barely a green flag in the second cohort, but this is not to be so happy, because you see that carbapenems that were already 10% in the first cohort climbed to 12%, so a little bit more, and vancomycin is also increasing. This is not too different to other PPS in the world, the global, the European, etc. But in terms of vancomycin, yes, it's higher in terms of carbapenems use in our region. So another extra red flag. The compliance with clinical practice guidelines overall were about 68 initially, now dropped to 63. So this should be red and not green. And it's interesting because it's always, we have a good compliance when we are prescribing for treatment. You see that 70% is good for treatment in both cohorts. And we thought that was awful when we published it in the first publication, the ISAC, the Journal of Antibacterial Chemotherapy, that less than half of the cases of prophylaxis was adherence to guidelines, but now drop more, even more, and it's less than 30%. This is mainly based not only that the first drug selected in most countries is ceftriaxone instead of cefazolin or cefalotine, so instead of first generation cephalosporins, but also that even in Chile, that it's one of the more rational uses, the antibiotics. Here are the rational results. We are not going into depth for every one of the countries, but even in Chile, the prolonged surgeries prolonged prophylaxis more than 24 hours after finishing after the surgery, it's in 2/3 of cases. So ceftriaxone use and prolonged in 2/3 of cases, even in the countries where the guidelines are more adherent. Regarding the prevalence of antibiotic use, usually predominating in ICUs and other surgical wards more than medical wards, this dropped a little bit, or about, not more than a little bit, about between 8 and 10% in the last study, but because we always have a but, or although, the GPC, the compliance with guidelines, also dropped from around 75% in adult medical to 64% in surgical units. Also it dropped. Unfortunately, we have a better adherence to guidelines in ICUs in the last study. So, to answer the questions made at 12 minutes ahead before, low proportion of culture collections and the escalation of treatments, microbiological results. We are not showing it then because we have not analyzed for the second cohort. In the first cohort, around 30% of patients undergoing antibiotic treatment had samples taken pre-antibiotic treatment, and only around 18% of patients have their treatment targeting to the microbiological results. So low proportion. In brackets, we have good, very good, and very proactive microbiological laboratories in all Latin American countries and in most hospitals, including the public hospitals that most of them were included in the study. Secondly, excessive use of self-generation cephalosporins, particularly ceftriaxone, and mainly for community-acquired infections and surgical prophylaxis, and carbapenems. In the first study, we have also near 10% of carbapenems as treatment in the patients being admitted with a hospital with a community-acquired infection. So the worst use is in SERV-G, then ceftriaxone, but also carbapenems. Increasing vancomycin use, prolonged surgical prophylaxis, as mentioned, and overall poor antibiotic use in surgical wards. So as you see, and that's the things we are recommended in our integrated feedback, we have first to put the eye when you begin a stewardship program, and if you are already doing it, keep on keeping the eye in the ceftriaxone use, carbapenems use, vancomycin use, the need of taking samples and the escalation according to microbiological results, and prophylaxis, surgical prophylaxis, and all the prescription, usually in surgical wards, also surgical traumatology, etc., etc. So it's a need of the commitment, a compelling need, an urgent need of the commitment of governments and hospital authorities to begin to implement and to strengthen the ASP programs, providing human and material resources to the teams and empowering them to develop the programs. No program will work, no antimicrobial stewardship program will work if we don't have the power to do it. We are usually fighting against dinosaurs, you know what I'm talking about. Disseminating antibiotic therapeutic guidelines, your guidelines, national guidelines, and now we have the new ISAC guideline that's very interesting, as you have seen. And then educate, have patients educate, continue educating patients. An acknowledgement, I have to say a great thank you to all our team that is here, the PAHO team, the headquarters, Robin, Jose Luis, Pilar, etc., and our mini dream team, Paola, Jose Pablo, and Jose Luis, all the Ministry of Health representatives, all country coordinators that you are seeing all here, and of course, more than 500 hospital investigators, we are 100 between gathering up all the two cohorts, more than 100 hospitals, on more than 5 investigative super hospitals, or many people work and help us to do that. And thank you very much for your attention.
So, ladies and gentlemen, today I'm delighted to present my work on interventional study focused on improving antimicrobial prescribing in hospital in Laos, which is known as Lao Antimicrobial Prescribing Application, or LAMPA project. Okay, so to start, I will give you an overview of situations of antimicrobial use and resistance in Laos. I will then discuss the situation of treatment guidelines in this country, highlighting the gaps that led to the development of the first local antimicrobial prescribing guidelines, Following this, I will present the result of the Stepped-wedge cluster randomized control trial, and then I'll share with you the key practical lessons learned of this project and wrap up with the summary. So before getting to our first, the first point in the list, let me briefly introduce you to Laos. For those who may not be familiar with the country, so Laos is classified as a lower middle income country with populations of around 7.6 million in 2023. The life expectancy is 69 years for men and 71 years for women. The country comprises 22 central and provincial hospitals with 135 district hospitals and over 1,000 health centers. We face a shortage of healthcare providers with only 0.3 physicians per 1,000 people, according to the World Bank data in 2021. This is well below the global average of 1.7 physicians per 1,000 in 2019 and lower than most surrounding countries. Recently, 12 central and provincial hospitals in 9 provinces and a capital of Laos have microbiology laboratory capacities. However, the limited access to diagnostic facilities in some regions of Laos is still challenging in ensuring timely and accurate diagnosis, as well as in monitoring antimicrobial resistance. So infectious disease are common in Laos. A review of AMR data from 1994 to 2020 in Laos by Chansamouth and in 2021 highlighted concerning trends. ESBL E. coli increased 5-fold from 7% in 2004 to 35% in 2016 in blood. And AMR pattern in other grass pathogens have been less concerning. You can find more information on these publications. The recent data from a large microbiology dataset at Mahosot Hospital from 2022 to 2023 showed that Burkholderia pseudomyeli was the leading cause of bloodstream infections across all age groups, followed by E. coli and Staphylococcus aureus. These findings are displayed in our AMR dashboard here, which is publicly available. However, we are currently updating the output format to improve accessibility, and we expect it to be available again soon. So cannot really next, okay, that's good. This table highlights the rising concerns over ESBL producing E. coli in blood and urine, as well as MRSA in both blood and non-blood specimens in Laos. As shown here, the average percentage of ESBL producing E. coli in blood and urine over these 4 years was above 50%. However, meropenem was added to Laos essential medicine list in 2019, but it was costly and limited to certain hospitals. Only recently, meropenem has been covered by the National Health Insurance. For uncomplicated UTIs, first-line treatment options like nitrofurantoin are not available in Laos. There is a growing concern of MRSA as well. There are infectious disease and prevention control committee in every hospitals in Laos and AMS programs in some hospitals. It's still challenging to manage MRSA patients in the country. Additionally, vancomycin is not yet on the National Essential Medicine list, although it can sometimes be found in large pharmacies. The access is inconsistent, especially during the period like the COVID-19 pandemic, which is so difficult to find. Though it's available, another challenge is that we have no access to therapeutic drug monitoring within the country. This makes it challenging for the country to manage appropriate antibiotic use and provide the best care for patients when some essential and life-saving antibiotics are unavailable. So now let's move to AMU in Laos. So before 2020, data on hospital antimicrobial use or AMU in Laos was really limited. Laos participated in the global prevalence surveys for the first time in 2017. And our first publication on AMU in Laos hospital was available in 2022. Findings showed a high antimicrobial prescription proportion of 71% among hospitalized patients in these participating hospitals. The most commonly prescribed antimicrobials were ceftriaxone, metronidazole, and gentamicin across all age group, with over 1/3 were used for prophylaxis, largely driven by obstetric and surgical prophylaxis. Adherence to local treatment guidelines was low, at only 26% based on correct antimicrobial agent selection only, mostly due to inappropriate antibiotic use for surgical prophylaxis. So since 2020, AMU monitoring in Laos has been expanded to include outpatient department. And in 2024, it was further extended to 11 provincial hospitals and 2 central hospitals. Our prevalence surveys data from 2020 onward now displayed in our AMU dashboard, which is publicly available and with automatically generated report. So people can visit the website if you prefer to. Here is the information on treatment guideline in Laos before 2021. The last editions of our national treatment guidelines were in 2012. With guideline covers, this guideline covers many important medical conditions such as non-communicable disease, obstetric and gynecology conditions. It also includes some common infectious disease in the regions and Laos, such as typhoid fever or malaria and so on. However, this lack of antimicrobial stewardship section. Most guidelines in Laos are national, with few institutional guidelines, and typically only one edition. For example, the surgical antimicrobial prophylaxis protocol for Mohosot Hospital was released in 1996 with no subsequent editions. However, some national guidelines, such as those for tuberculosis, malaria, or HIV/AIDS, have been updated intermittently. Here are some key reasons why the first Lao antimicrobial prescribing guidelines were developed. With the high proportion of antimicrobial prescription in Laos and a lack of access to local evidence-based guidelines. In addition, a study by Fabrice et al. On antimicrobial prescription behavior in 25 public hospitals across 4 provinces in Laos found that the most Lao doctors prefer local treatment guidelines over international ones. One possible explanation is language barrier, for example. However, access to this guideline is often limited. In Laos, guidelines are typically available in a paper format, and the numbers of copies distributed depends on the budget. As a result, even when guidelines exist, many healthcare providers may not have full access to them. Therefore, the first comprehensive antimicrobial prescribing guidelines were developed under the agreement and collaboration between Ministry of Health and Infectious Disease Society, Lao AMR Committee, and Laos Oxford Mohosot Wellcome Trust Research Unit. These guidelines were based on our local AMR data and antimicrobial susceptibility profile, drawing on existing national treatment guidelines to avoid duplications, along with international recommendations. So the development process took approximately 18 months, involving extensive consultation with senior law doctors, local and international experts. In December 2020, the Department of Healthcare and Rehabilitation of Ministry of Health officially approved the guideline, which became available for the use in January 2021. I subsequently converted the printed guideline into a digital format with the MicroGuide mobile phone application. So some of you might question, like, why MicroGuide? Well, MicroGuide was an offline platform and it could read loud. We could get the data on the use, which we were looking for when we started the project. In addition, our senior colleague, Director of Cambodia Oxford Medical Research Unit, Professor Paul Turner, has already pioneered this app in our network. However, now MicroGuide platform changed its name to EOLAS. I'm sure that some of you might have been aware of this. So these days, more and more healthcare professionals are using smartphones in their daily work. Studies have shown that mobile applications are an effective way to deliver clinical guidelines. Previously, research on antimicrobial prescribing guidelines adherence delivered by smartphone was so limited. Recent publications indicate that adherence rates improve after app implementation, with healthcare providers accessing guidelines via app more frequently than through other formats, for example, desktop or PDF or something like that. Most of these publications focus on the app converting from existing prescribing guidelines to mobile phone format, while a few research focused on a brand new guideline. So once the guidelines were available, with the evidence suggested that mobile app could enhance prescribing practice. To address this, the Lao Antimicrobial Prescribing App or LAMPA project was conducted. This also presents an opportunity to introduce mHealth solutions in Laos. If successful, this could save on printing and distribution costs and make update easier and faster. The main objective of this study was to compare the proportion of antimicrobial prescription adherence to the prescribing guideline delivered by a paper-based version and a mobile phone application version among both in and outpatient across six hospitals in Laos over 16 months period. These presentations, I will focus on hospitalized patients only, as this might be too long if I cover both in and outpatients. So the main reasons why these 6 hospitals, so these 6 hospitals were purposely selected. It was because they previously participated in our AMU surveillance and also their locations. The hospitals include 2 in the north, 2 in the centers, and 2 in the north, 2 in the center, and 2 here in the south. This study was a step-wedge cluster randomized controlled trial with 3 steps. The interventions included the antimicrobial prescribing guideline in mobile app format and training on good prescribing principle. The reference group were the paper-based versions of the same guideline. Training of the use of each version was provided immediately after distributing the guideline. Oh, sorry. So here is an overview of how we conducted the Stepped-wedge cluster randomized control trial. The Stepped-wedge cluster randomized control trial was selected as it requires fewer sites than parallel trials, but has similar observational periods and control and intervention phases. And we could be sure that all clusters had access to the interventions. As the interventions were delivered by one team traveling to each cluster in turn, implementing in stage was more practical. So this is a three-step trial. We collected data on the data on baseline data on Mancello before distributing the paper-based guideline to all 6 hospitals. The green area is the group with paper-based guideline, or we can call this group like PPG. And the blue area is the group with the app-based guideline and good prescribing principle training, which the term AppG was used for simplification. The baseline data collection, the first pair hospital, So the first pair hospital, after baseline data collection, the first pair hospital were randomly selected to have access to the AppG or intervention, ideally every 4 to 5 months. This process was repeated for second pair and the third pair until all hospitals have access to the interventions. So the outcome of interest were measured using repeated prevalence surveys, prescriber surveys, and AMS knowledge surveys. For this presentation, I will focus on full guideline adherence using data from prevalence surveys. So full adherence for this study was defined as prescription with the correct antimicrobial agent and correct dose. The duration was not included in this adherence measure due to the nature of the prevalence surveys, except surgical prophylaxis, which would be single-dose prophylaxis or one-day prophylaxis, so we could capture using prevalence survey. So the aim for 16-month study. However, with the consequences of COVID pandemic, the study was expanded to 22 months. Guideline distributions was greatly supported by Ministry of Health, directors of hospitals, and very welcomed by prescriber. By the end of these studies, over 400 prescribers from 6 hospitals had access to PPG, and nearly 400 had access to AppG. Antimicrobial prescription proportion were similar across groups, with over half of patients in each group receive a single antimicrobial. Nearly all prescriptions were empiric. Antimicrobial prophylaxis accounted for about 1/3 of all prescriptions. Documentations of stop or review dates of antimicrobials was poor. Of 3,561 prescriptions, the most commonly prescribed antimicrobials across all age groups were cephalosporin, nitroimidazole, such as metronidazole, and penicillin. Among cephalosporin's group class, ceftriaxone made up over 84% of total use in each group. Here is the use of WHO-aware antibiotics by age group. As you can see here, the use of access group was below 60% for children older than 1 year and adult. We could observe the use of non-recommended antibiotics here, which is ceftriaxone sulbactam. This was found only in adult, in surgical ward, and in one hospital only. It was used for surgical prophylaxis. So prescribing indication varies by age group. For children under 5, sepsis and pneumonia were the most common prescribing indication. For adult, antibiotics were frequently prescribed for obstetric prophylaxis, such as C-sections and normal vaginal delivery. In older children and adults, prescriptions often lack a clear indication, with some having no documented diagnosis or a diagnosis unrelated to infection treatment or prophylaxis. If we just focus on the prescribing indication of treating infection only, pneumonia was the most common indications, followed by sepsis and appendicitis for all age group. So of all prescriptions, 91% has sufficient information to assess guideline adherence. Among unaccessible prescriptions, majority of the indications were not included in the guidelines or with unclear indication. Here is the proportion of guideline adherence in the pre-guideline group and the PPG group and in the app group. As you can see here, the overall adherence to the prescribing guideline in the app group was significantly 68% higher than in the PPG groups. However, when adjusting for potential confounders, such as patient age, sex, department, prescribing indication, type of prescriptions, either empiric or targeted, and sequence of intervention implementation, as well as accounting for the time and cluster as random effects, adherence in the AppG group was 20% higher than in the PPG group. However, evidence insufficient to conclude that adherence in the app group was better than in the PPG group.
So, Dr. Vilada, could you come to a conclusion? We would like to have some time for questions still. Thank you.
Okay, so I just go to this quickly. If you see this slide, you will see that the higher adherence observed when the group of hospital export to the guideline earlier. So the earlier you export to the guideline, the higher adherence that you would have. And this one is just the reasons why the adherence is so low in this country. So as I have said before, that most of them is due to the surgical prophylaxis. For non-adherent for surgical prophylaxis, 80% was incorrect agent and durations, 12% incorrect agent dose and wrong duration. Basically, those who had non-adherent for surgical prophylaxis had wrong durations. Antibiotic prophylaxis for normal vaginal delivery in Laos was really common. So in our study, we found that 100% of patients of the mother who come for normal delivery, so they have antibiotics back home. So pneumonia was the most common prescribing indication at all age. So, but there's no difference after introduction of the interventions, but the adherence was 97% lower in adults compared to in infants. So this one is the data from self-report. So our prescriber, they claim that more than 1/3 of them claim that they access pocketbook nearly every day. This is self-report, so we do a survey questionnaire, and then more than 1/3 of them say that they access pocketbook nearly every day, and nearly half of them said that they access the app nearly every day as well. However, the data show that the data from microguide show that actually the average on app access is just 25 times per prescriber per 22 months. or approximately once a month. And the most frequently searched topic is melioidosis, pneumonia, and the name of antimicrobials. So in Laos, the proportion of antimicrobial prescriptions was high, and guideline adherence was much lower than other low-middle income countries. Non-adherence was likely influenced by surgical prophylaxis and prescriptions for normal vaginal delivery. Our findings indicate that the earlier exposure to the guideline was associated with the higher adherence. However, there was no significant difference in adherence between paper-based guideline and app-based guideline, although the 95% confidence interval was narrow. That could be because of the study was under power to detect the difference due to small number of hospitals. A recent qualitative study that we conducted revealed that limited antibiotic availability and influence from senior colleagues could impact prescribing behavior. Additionally, our study's pragmatic design means we did not actively manage guideline uptake within hospital, which may have led to low successful rate. The trial also faced COVID-19 related challenges, including reduced patient numbers and prescriber preoccupied with pandemic response effects. So improving appropriate use of antimicrobial needs several factors, including easy access to life-saving antibiotics when needed, good laboratory supports, antibiotic use guideline with the country situations, with training, promote of the use, monitoring, and the most important thing is that the healthcare leaders must get involved and support. So thank you very much for your attention.
Thank you so much, Dr. Heiman, and thank you for the International Society of Antimicrobial Chemotherapy for this invitation. I would very much appreciate the work that you are doing, in particularly considering that there is a huge gap in terms of availability of resources in guiding clinicians when it comes to targeted therapy. I think this is a tremendous effort that has gone behind the development of this product, and I'm sure it will be of great help for particularly to the low middle income country hospital and clinical facilities. So in the next maybe 15-20 minutes, I would try to cover from the WHO Eastern Mediterranean region what are the progress that we have achieved in terms of the antimicrobial resistance programs in our countries. What are the challenges and a few priorities that we have identified for addressing the next few years. And as Dr. Hind mentioned in her talk, we see increasing issues of humanitarian crisis around the world, and particularly our region is home to a huge number of population who are displaced internally as well as to other countries. Our region is very diverse in terms of the economic status. For example, we have 6 high-income countries. Then we have the middle-income countries, and then we have several countries which are fragile, conflict-affected, and vulnerable. And there are always several emergencies that happen in several of our countries, and besides all the other ongoing issues which are chronic. I'll come later to the details of why we put that at the first slide. So I'll come to that in a while. And today we know that we have the most recent estimates on and the predictions for the next 25 years in terms of the burden of AMR. But if you see the previous numbers from 2019, we can see that the region had around 10% of the global attributable AMR burden in the world. So it's all we should start actually speaking from the sepsis, bacterial sepsis, which I think is also very key to what we are discussing today in terms of the antibiotic guide. Around 1.1 million deaths in the region in 2019 were due to bacterial sepsis. sepsis, of which around 770,000 were due to bacterial sepsis. So that means we are talking about around 16% of the deaths which were due to bacterial sepsis in the region happened just because of antimicrobial resistance. So at one side, we have a huge problem of antimicrobial resistance. And at the same time, we also know that with all the conflict and all the issues related to the fragile health systems, we have an access issue, which also hinder access to essential antibiotics in many of our countries. The data available on antimicrobial resistance are limited. We know that there are limitations to whatever data we are talking about, but still, whatever data are available, all of them hint to the same fact that there is an increasing trend in the resistance. Particularly, if you see this graph, which shows the increase in the trend in the key indicators that we use for tracking the global development indicators. As I mentioned in the beginning, it's important that we contextualize, particularly in our region, the ongoing the emergencies. It's not just the war, but also in terms of migration and forced migration that is happening. There are enough evidence that we have in terms of the impact of the war and the migration on the burden of AMR. There are enough studies and data that have come up with facilities that have been treating these patients in multiple countries of our region that show that wars and these calamities and these conflicts contribute to the ongoing problem of antimicrobial resistance. A bit on how or where our countries stand in terms of the progress. So we know that globally we had the World Health Organization coming up with a global action plan on AMR, which most of the countries adopted and then started working on them. They have their own national action plans. If you see the progress, this is from the recent self-reported data from the countries, which actually ask the countries to self-assess where they are in the process of reaching the best possible scenarios. So if you consider countries which have reported that they at least consider themselves have reached at least the midpoint of the progressive stage, we find that in some of the areas our countries have progressed very well. But if you look into the last pie chart, you can see that the optimized use of antibiotics, we are very much lagging behind. So there is definitely some progress in infection prevention control, and it was also helped a lot by the pandemic in a way. But also, there is some significant movement in terms of One Health, but we have a lot to do in terms of optimizing antimicrobial resistance, use of antimicrobial resistance. Most of our countries have a national action plan. So the national action plans, which actually tells what the government is planning to do with all the other stakeholders involved in terms of a period of time that they want to do the programs. So, one of the key things that we see that many countries are yet to have a multi-sectoral coordination mechanism, because we know that antibiotic use happens outside the human health sector, which has a tremendous impact on how antibiotics will work ultimately in human health in clinical settings. So this is important that, as clinicians, we understand, and also as practitioners, we realize that, things have to happen in non-human health sector so that we can continue to have our antibiotics working effectively. And also, many of you might have heard about the people-centered approach. This is, the World Health Assembly this year considered a new approach in terms of how we govern the national action plans and our global efforts on antimicrobial resistance. So we need to have, most of our countries are yet to have allocating specific budgets, even though they have a plan. We do not have sufficient resources to implement those plans in many of our countries. Infection prevention and control is one area where we had a significant improvement, but there's still some of the areas, as you see here, highlighted, which needs to be improved. The foundations are strong, but we need to sustain what we have achieved so far, and we have to scale it up. And as you have seen, reports after reports, evidence showing very clearly the infection prevention and immunization and improving the water hygiene and sanitation measures are very critical to addressing AMR. Countries are, under the National Action Plan and the Global Action Plan, countries are supposed to monitor the resistance pattern in their countries. Countries are supposed to monitor the use of antibiotics. Again, this is self-reported data from the countries, which show that we still have a long way to go when it comes to monitoring of antimicrobial use. Systems have been in place for the monitoring of antimicrobial resistance to some extent, to a large extent. There are improvements in many countries, but the problem is that we are still far away in terms of monitoring the antibiotic use. Not only that, another key problem that we all face is that countries generate a lot of data on resistance, particularly, but how far are we using them? This is also linked to the antibiotic guide. How can we effectively start using the data on the antimicrobial surveillance and use it for clinical purposes, decision-making purposes, not just at the policy level, but also at the clinical level. So I think this is something which we have a lot to improve on. And in many of our countries also, we have issues of lab strengthening capacity of labs, including human resources, which has to be improved so that we can improve the way that we monitor antimicrobial resistance. Monitoring antibiotic use is a very difficult task. We know that there are various ways and methods that we talk about, but all of them have their own limitations, and many of them are like very resource intensive. So, but we have to find out ways we can start using them in the facility level so that we can use this data for stewardship. This is, again, one of the major priorities that we see in the coming years. We have, many of our countries do report to the WHO global system, which is essentially coordinating the data on surveillance and antibiotic use at the global level. We have fairly good reporting from the countries on the resistance data, but again, in terms of reporting on the antimicrobial use, we still have a lot of scope for improvement. Besides reporting, what is the issue? The quality of data, and also in many countries, probably the reporting of antimicrobial resistance come from a few selected centers, which are not a representative of the general population-based or a primary care level resistance pattern that we should be seeing. So there is always this problem of how far we can rely on data from one center and then use it for another center. So this is always a problem when we think of targeted therapy and use of, and we need a lot of investment in terms of improving the use of the data. So when it comes to the critical things that we are talking about today, the antibiotic use particularly, our region, which has 22 countries, has the highest and the most rapidly rising use of antibiotic use. So this is something which is particularly a problem which we are aware about, and we have to see like how we can reduce the use of antibiotics. But then we also know that there is a huge inequities within the region between countries. So if you see in this graph, you can see that although we have a very high rate of resistance compared to the global average, within our countries, we see that high-income countries had very high rates, but recent years coming down. But if you see the middle-income countries, they are really driving the increased use of antibiotic in the region. So it's a low middle-income countries which has shown significant improvement, significant increase in the use of antibiotics. So how much of this increase is appropriate, is based on evidence, is actually required, is something which requires more data from the country level to look into. And we also see that, as I mentioned in the first slide, that the fragile conflict environment is really a big problem. We really need to address these situations to improve how we address AMR. You can see that the fragile countries, they report very low consumption of antibiotic, per capita consumption of antibiotics. Either there's a huge informal market which we do not capture, or there is really a problem of access to antibiotics, which is a real concern in many of our countries. And we already heard about the access watch reserve classification by WHO, which actually provides a really straightforward way of empirical management of common conditions. But then, countries are taking up the AWARE classification and those guidelines to embed them into their treatment guidelines, or how they manage their national list of essential medicines, which should guide actually the procurement in most of the countries. So still, there's a significant number of countries who are trying to do that, but the treatment guidelines, incorporating the AWARE classification, we have a long way to go. But we also realize that many of our countries have issues beyond their control. Supply chain issues in the region, and even globally. We saw how much of a shortage of simple antibiotics have happened after the COVID, shutting down the whole supply chain systems. So this all interlinked. So we have to have strong mechanisms which can support the global supply chain mechanism, which will provide our clinicians an opportunity to prescribe the most appropriate antibiotics. So it's a chain of events that will ultimately result in a most appropriate use of antibiotics. Towards the end of the presentation, so I would really want, as clinicians, as providers of health services, to be aware of this. We really need to have antibiotics in place. We really need to have new antibiotics coming up. We really need to train our doctors in improving the prescription of antibiotics. But we also should realize that whatever evidence, as I said in the beginning, all show that we need to really focus on the prevention of infection. And prevention of infection should include IPC practices in the facilities as well as in the community. We need to have real investment, and as clinicians, we need to advocate for improved investment in water, sanitation, and hygiene. And it's also in the facilities, basic water, sanitation, hygiene facilities in the facilities, where clinical healthcare facilities, but also in the community. So we have an increasing responsibility to do this. And as mentioned when the antibiotic guide was presented, the diagnostics availability is a problem. It has many dimensions. One, of course, is directly linked to the unavailability of these diagnostics in many facilities. Second thing, we also need innovations happening in this field. We need innovative point of care, affordable diagnostics, which can tell us the pattern of resistance. I mean, of course, I come from India, and we know the challenge for treating tuberculosis, multi-drug resistant tuberculosis, for several decades that we were unable to do this at a point of care or a primary care level. In the last 10-15 years, we have a range of products which help us to do that. So we need similar investments, similar initiatives which can help in the general, antimicrobial resistance world for us also to improve the diagnostic capacity. So at the regional level, the countries are going ahead with a new approach, which actually is based on the global people-centered approach, which actually provides a lot of emphasis on the prevention of infection, and also ensuring that the governments provide budget for the actual implementation of the national action plans. National action plans need to be operated. And then there we have challenges. We have all the emergencies that happen, and the conflicts and other challenges in the region. We need to have adequate preparatory mechanisms in our operational plan for emergency and preparedness, so that we do not forget AMR. We need to make sure that antibiotics are available as part of the emergency kits that we provide. We need to make sure that IPC and wash and vaccination services continue to happen, so that we do not have resistant pathogens, which will complicate and increase the cost of care. We need to ensure the essential health services, as we mentioned, the basic essential antibiotics as well as diagnostics in all the facilities. Of course, we also have to strengthen the data that are coming out from our laboratories in terms of both the use of, in terms of resistance, as well as the use of antibiotics at the country level and the facility level, which can then help us guide the stewardship activities. And I believe the antibiotic guide and other similar tools are going to be very, very helpful in a directed therapy and in our stewardship efforts. Thank you so much for listening.